everyone. Today's topic is coronary and peripheral balloons. We'll discuss from plain balloon angioplasty to the advanced IVL. Myself, Dr. Gaurav Behra, Assistant Professor in Department of Cardiology, will be discussing this. This is very important for residents who are just entering to the cath labs. Just a basic principle and what coronary and peripheral balloons are. Let's start. So the objective of this topic will be the how to know the master balloon physics. We will know the device family, which group it belongs. We'll talk about IVL. We'll talk about lesion specific balloons, which balloon to select for which type of lesion. We'll discuss about the evidences from the trial, and we'll also discuss how to anticipate complication in the different types of balloons. So roadmap, mechanics, then we'll discuss coronary, emphasis to lithotripsy, peripheral balloons, and the integration. So it's 1977 when the first Grins performed the first balloon angioplasty in Zurich, which subsequently now in 2003 there is a DES era came. With subsequently there are evolvement of different stents which decreases the polymer size, the size of the stent, the density of the polymer, it's starting to decrease. And now the era people are discussing only nothing to lift. It's drug-eluting balloons. So we'll discuss each one by one. So first, mechanics. Now, what is a balloon made up of? Like balloon membrane, it's a folded polymer. It defines the compliance and the behavior of the balloon. The second, the proximal and the distal shaft. Will come to the diagrams. You can easily, like it's a hypotube with a polymer. There are transmission pushability and tracks the wire. There are different parameters. Now, inner lumen, that's the guide wire passes through that balloon. The inflation lumen, which separates channel delivering contrast mix to inflate the balloon, which inflates the balloon. Then the radio opaque markers that is present within the balloon, and the tapering tip, which is atraumatic. So this is a balloon cross section of the balloon catheter. You can appreciate in the left side there is a catheter shaft. In between you can see there is a guide wire lumen where the guide wire passes, and there's a balloon membrane that is made up of polymer which defines the compliance of the balloon. So in right side you can see the balloon image. There are two dots within the balloon. They are the radio opaque markers. Please notice that the markers are started after the convergence of the balloon. Means balloon extends beyond that radio opaque marker. So this is a diagram: shaft, guide wire lumen, balloon membrane. So there are two types. One is the over the wire. Over the wire means you can see in this diagram. Over the wire means there is a two separate port in the distal end. From one you will inflate the balloon. The one which is angulated will inflate the balloon from there, and the straight one the guide wire will come. So that is over the wire technique, mainly used for peripheral. But the second one, advanced, that is monorail catheter. You can appreciate that there is only single port in the distal connection. So distal, you inflate, you attach the inflation cap to that distal port, and you can appreciate that initial there is a black marker in between. That part is a monorail system. So you can deploy balloon very easily, and there are multiple instruments you can pass through that. So monorail catheter and over the wire. Now you can see over the wire, guide wire runs over the full catheter length. It allows wire exchange and distal pressure injection. In monorail system or rapid exchange, you cannot give dye through that balloon catheter. Needs two operators, because over the wire you need to exchange over the wire, so you need two operators or long wires. Normally wires 190 centimeter is not enough for that, so it requires two operators because long wires are required. It's high profile and there is slower exchange because you have to hold the balloon over the wire. In rapid exchange, this is exit through a proximal part 25 to 30 centimeters. You can do single-handed fast exchange, and there is a low crossing profile because over the wire are bigger balloons. So you cannot inject drug and cannot exchange wire through that. And default for most coronary and peripheral balloon, but over the wire is mainly for peripheral procedures. So there are various terminology you should know, like what is nominal pressure of a balloon. The pressure at which the balloon reaches its labeled or nominal diameter, that is the starting reference range. Likewise, if a balloon is named like 312 or 315, so the pressure at which the balloon reaches that 3 mm diameter, that's the nominal pressure. Similarly, second term you should know RBP, what is rated burst pressure? The pressure at which the more than 99.9% of balloons survive with 95% confidence. So this is the limit. You are not allowed to go over the RBP of the balloon, because there is exponentially risk of balloon rupture if you reach to the RBP. Now what is mean burst pressure? Now, when mean rupture pressure is more above the RBP. So these the RBP and mean burst pressure are need not to achieve. You just nominal and always below the RBP. So the compliance, what is compliance? Compliance is same as what the literal meaning of compliance is. As per the increase in the per atmospheric pressure, how the slope of compliance curve changes. We'll come to that in the next slide. Then working pressure range is the nominal to RBP, you know, and balloon artery ratio, usually we 1:1 will come to that pre-dilatation, post-dilatation, but reference is the diameter, what balloon to the artery ratio, either it's less than 1:1 or more than 1:1. So this is curve. You can notice that the red one is semi-compliant. So both the balloon, both reaches to diameter of nominal pressure at the same pressure. You can appreciate that in at the 6 atmosphere or 8 atmosphere, you can reach, both balloon reaches to the same point at 8 atmosphere pressure. But as you can look to the semi-compliant balloon, the upper curve, as the pressure increases, the balloon grows well beyond the nominal. So non-compliant gains for less pressure. But therefore, non-compliant has predictable diameter at high pressure. You can see that green one, the non-compliant balloon, at high pressure, the diameter do not changes. So this says this is non-compliant balloon. So what are the uses? I'll come to that. So the compliant system. So compliant means behavior that is elastometric, large diameter changes with the pressure. If you increase the pressure, the diameter of the balloon changes. This is what is compliance. So this is used in valvuloplasty or occlusion or aortic interventions, but we rarely use this compliant balloon. Even we do not use compliant balloons in coronaries. The second is semi-compliant balloon. Semi-compliant means there is a predictable change in the diameter, like usually less than 20% growth. So semi-compliant balloon, we mainly use this for pre-dilatation, for exchange, or these drug coating balloon platforms. And coming to non-compliant, so there is minimal growth. If diameter is 3, then it will 3.1, 3.2. It will not change more than that. So you can go to high pressures with the same diameter. So this is typically used for post-dilatation and post-stent optimization in pot balloons, the pre-optimization techniques. Now the last one is super high pressure NC balloons. So these are specialized balloons which has 2 layers and they can tolerate pressure up to 35 to 40. So these are used in special situation when there is a stent under expansion or undilatable lesions. So mostly this is used post dilatation for under expanded stents. So coming to the chart that will clearly defines the difference between the semi-compliant and non-compliant balloon. They're very important. Semi-compliant balloon is mainly made up of nylon and Pebex blends, and where non-compliant are polyurethane based. As known, compliance is high, it expands with the pressure, but non-compliant, minimal growth. So good crossing profile or better profile with semi-compliant, so therefore it is used for pre-dilatation, whereas crossing profile of NC is slightly higher. So rapid burst pressure are usually semi-compliant within 12 to 16, but you can higher pressure with non-compliant balloon, and even special scenario of OPN balloon, we are talking about double layer balloons, pressure more than 30. So this is a dictum or pre-dilatation for wiring and exchange, we use semi-compliant balloon, whereas for the post-dilatation and stent optimization, we use non-compliant balloon. So when you should be very cautious when you are using semi-compliant balloon with high pressure. So edge dissection, because there is uneven expansion with semi-compliant, so there are chances of edge dissection. Whereas there is predictable increase in the diameter with the non-compliant, so there is a less risk for the dissection. So the pearl or what the point, semi-compliant for the work, non-compliant to finish, and high pressure for the post-dilatation. So this is the standard: semi-compliant when you are starting the work, non-compliant balloon for finishing the work, and high pressure non-compliant balloon is post-dilatation when you have under expansion. Now, how to size and what is the inflation principle? Balloon to artery ratio usually 1:1 to the reference segment. You can use by QCA diameter through your angiographically or eyeballing. As you do the angiographies, you will definitely come to know what is the size of the vessel. As per your experience, you can use 1:1. So when you are doing predilatation, ideally you should take 0.5 to 1 mm less than the size of the reference diameter for to prevent dissection and the proper predilatation. Post dilatation always to be done with 1:1 stent, and there should be short inflation and high to embed struts. That means that 1:1 for the non-compliant and usually a 0.5 size lower reference in predilatation. So adequately, when you want to know exactly what is the size of vessel, the true thing is the imaging. So if there is a complex cases or if there is calcium, or you want to know the what is the different pathology behind that, so in that cases you can do imaging and you can very well know the actual size of the vessel. Now distal vessel tapering, that means this line states that when you are taking a run through the imaging, you should take run from distal to the proximal. So you can do a proper sizing, like small size for the distal and as well as accelerate the size of the balloon. So how to inflate the balloon? So there should be gradual inflation, 2, 4, 6, 8, 10. You read the pressure and you should not eyeball. You should focus the reading of the inflated device. So now the second thing, what important, you should hold the inflation long enough. You should see the inflation of the balloon, how the balloon is expanding. So you have to see that in the fluoro, that how the balloon is expanding. Is there any waste in balloon that will lead to resistance, that will lead to inadequate expansion? So you should look to the fluoro as well, and never exceed RBP in a calcified lesion that can cause rupture or perforation. Now, if there is a persistent waste in fluoro with that balloon, you can escalate your different balloon like scoring, cutting. I will come to that in. But don't jump to higher pressure. Like if you're pushing a balloon of 3.5 to 20 to 24 and still waste is there, then you need to intervene something else. You have to do OPN or you have to do IVL. That will come later on. Now, especially coming to what balloon angioplasty. So this is plain old balloon angioplasty, that initial days from 70s to late 90s, what cardiologists used to do, that old balloon plasty where act by plaque fracture, intimal dissection and axial plaque redistribution. So this is the, in initial 20-30 years, this is the standalone therapy for angioplasty. So, but the problem is that the most important thing, that is the disadvantages, there is elastic recoil because the vessel wall has media, so that can have a different complications like abrupt closure, there is negative remodeling that can cause again restenosis. So lesion preparation is very important before stenting. So what we have discussed, semi-compliant balloon, you have to do less than 0.5 to 1 mm diameter. And if there is a very small vessels, then now there are drug coated balloons are available. And this is the principle, leave nothing behind. Means you keep the patient with what he has. Means you are not putting there any kind of metal or any polymer. You are just leaving the vessel with some drugs. So this is the new concept, leave nothing behind. So that these limitations, the elastic recoil, the dissection, the restenosis and the resistance of calcium, so these leads to development of various balloons. So this already we have discussed, predilatation is ideally required in all patients. A second strategy is direct stenting, which is not usually recommended. Now there are specific balloons that I'm going to discuss. You can see the leftmost scoring balloon. So this is a helical natilol element score. Why scoring balloon? Because score balloon, there are a balloon. If this is a balloon, there are 2 or 3 wires that are arranged helically over that. So there are various balloons, angiosculpts, Scoreflex balloon. So they are used, means if the advantage is that if balloon has different wire over it, it will adhere to the lesion and it will prevent slippage of the balloon from that particular lesion specific area. So first is scoring balloon, then second is cutting balloon. So nowadays what we use our institute is Wolverine Boston Scientific cutting balloon. There are different microtomes. You can see in this diagram, I'll say in the coming slides, there are 3 to 4 microtomes. If the size of balloon is 3.5 or more than 3.5, there are 4 atherotomes or microtomes that in size like 1, 2, 3, 4 that cuts the your plaque or calcium or fibrocalcific lesion. So this is a type of plaque modification balloon. Now the super high pressure NC balloon, you can see in the diagram, it is a twin layer balloon that can withstand pressure up to 35 to 40. Okay, and the third being, then the last being IVL, that is intravascular lithotripsy. So these are the balloon which produce sonic pressure that fractures your calcium. We'll come to those videos later on. So cutting balloon, we already discussed this, 3 or 4 microtome blades high mounted on a non-compliant balloon. So blades create discrete endovascular incision. So the main mechanism is it form incision so you can easily penetrate to the inner surface. So there is a controlled fracture, reduced dog boning or balloon slippage for melon shedding, what we have already discussed. If wire is present around the balloon, it can easily adhere by friction mechanism. Okay, and one thing that you have to always remember, there should be a slow inflation and slow deflation when you are using a cutting balloon. So what are the uses of cutting balloon? So it is best for fibrotic and fibrocalcific lesion, or if there is a case of ISR, or in bifurcating lesions when your calcium is present, or if you are getting waste in a non-compliant balloon. So ISR, if a patient is having resistant non-dilation or resistant lesions, so you can use this cutting balloon. Now this is a slide that shows that as you increases, like the blue one, no, the blue one is saying that NC balloon, whereas the purple one is belong to Wolverine cutting balloon. So this is a slide from Boston Scientific. You can see that if the 12, when you increase the pressure from 6 to 12, the peak tensile strength exponentially changes. So at the 12 atmosphere pressure, what the difference between the NC is cutting is clearly seen. So you can see stress distribution in the calcification model of cutting balloon at 12 and NC balloon 12. There's so much difference. So this is a very good tool for plaque modification, calcium management, but you should know when to use and how to use. That's very important. Now scoring balloon we have already discussed. This is an external nitinol element, helical cage, that is angiosculpt, and single eccentric wire, that is Scoreflex wire. So as you keep, you have to manage that balloon in, like you have to place the balloon in the plaque region and you have to subsequently increase the pressure. So what practical scenario, cutting balloon is better than scoring balloon, but some studies says that scoring balloon have a good crossing profile and better deliverability than a cutting balloon. So therefore sometimes for distal lesions where you want to have desired dissection, Scoreflex balloon can be used. So the same indications what we have seen with the cutting balloon, moderate fibrotic lesions, ISRs, different bifurcation side branch lesions, or same when you want a desirable dissection before putting DES or DEB. So now we have already discussed, there are the various companies with the Wolverine Boston. It has 3 to 4 atherotomes. Angiosculpt from Philips, which is a scoring balloon. Scoreflex from Orbush with scoring balloon. There is a Braun NSC Alpha, it is also a score balloon. And Medtronic has with chocolate balloon, which is atraumatic, and it has a groove retinol case. There are various groove inside the balloon that's also used for this plaque modification. So the selection logic is scoring balloon tracks better and with distal tortuous lesions. Cutting balloon delivered deeper, more discrete incisions for fibrotic ISR and resistant osteal plaque. And these both reduces slippage versus plain POBA. Plain POBA means what we have done NC balloon, if there's a calcium or some fibrotic material, so this will adhere to the lesion and there will be good desired dissection or desired plaque modification. So this is the third one, what we have discussed, high pressure ONC. So it has been seen in some trials that ISR Cal OPN improved the stent area when there is an under expansion, when you are using in those calcific lesions. It has been seen in study that in calcified lesion post dilatation with OPN balloon, it improves the stent area as well as the outcome. So when you are using like IVL or atherectomy, so these balloons can also be used, but to use OPN balloon within the stent is safe rather than using in the native vessels. So obviously the most important is it is a bailout for the under expanded stent that won't eat. Now coming to the recent one, that is drug coated balloons. So the concept is leave nothing behind. So these are semi-compliant balloon coated with anti-proliferative drugs. So these drugs are paclitaxel or sirolimus. So these balloons are inflated in the desired area with every balloon has a definite time for the drug delivery, like 30 to 60 seconds. Some balloon has 30, some has 60 seconds. So there is no permanent polymer or metal with the vessel. So the main advantage is this: you can use this patient in those are allergic to metal, those you don't want to put a metal, or those are small caliber vessels. But one thing is important: DCB readiness. Before putting a drug coating balloon to a vessel, there are certain criteria. Likewise, there should be an adequate predilatation, 0.8 to 1:1 to the vessel. There should be no residual stenosis, no, that means there should be acceptable residual stenosis like 20 to 30. There should be no flow limiting dissection. Like if a patient is having flow limiting dissection, then there is a TIMI 2 flow or having no flow. In that condition, you are not allowed to put DCB. And there should be good flow maintained. And if there is a flow limiting dissection, you have to bail out stent in those conditions. So there are certain criteria you should remember before putting DCB to the vessel. So paclitaxel versus sirolimus. So mechanism, the paclitaxel is microtubular stabilizer, cytotoxic, whereas sirolimus is a cytostatic. So lipophilicity is high, so therefore rapid uptake is seen with the paclitaxel, but sirolimus is less lipophilic. So it requires crystallization over the balloon for delivery. So therapeutic window is narrow for paclitaxel, whereas the safer profile of the sirolimus. Now companies are coming with the different sirolimus drug coated balloon as well, and tissue residence is long, whereas shorter with the sirolimus. So therefore it requires different crystalline form and various carrier technology to deliver to the vessel valve. So presently, if there is a most evidence are with paclitaxel drug coating balloon with the ISR in the small vessels. There are different trials, we'll discuss that. And similarly in sirolimus, there are less studies and ongoing RCTs are going with the sirolimus drug coated balloon. So paclitaxel remain the reference coronary DCB. Sirolimus are an active area of development, and this is attractive because there is a safer profile because therapeutic window is large. So in coming days, you will be seeing sirolimus DCB as well. So what are the indications for coronary drug coated balloon? We have discussed this. The patient having ISR. The second, the patient having small vessel diameter, where you are putting the stent will not give you a desired stent area. And third being those patients who are having high bleeding risk. You cannot put the patient on dual antiplatelet or strong antiplatelet for a longer time. And when you need to prevent a side branch, like when you are dealing with a LM bifurcation, if the size of LCX is more than 3, then you can stent. But if the size is less than 3, 2.5 to 3 something, then you can do a sandwich technique where stent in the one main branch and LCX with the depth. That will give you good results. In coming days, we will be having studies with that. And in diffuse long disease, where there is no definite stent delivery area, you can put DCB there. And as discussed, small vessels. So there are PEPCAT trial where the DCB was superior with stents for ISR. That shows 1-2 year follow-up. They are doing good. There are various trials, basket 3, agent. They are superior to balloon plain angioplasty. They'll be definitely better than POBA because they are giving drugs to the vessel as well. So main large trial or large evidences are required now to head-to-head comparison with the DCB versus DES. So it is definitely solely depend on the operator that what he has to do by looking to the clinical profile of the patient. So now coming to the advanced IVL. So the main thing is IVL is when your resistance lesion, resistant calcium or plaque. So when calcified plaque is rigid and inelastic, when there is a, we have discussed that melon seeding or resist balloon expansion. So in these conditions, you can use this IVL. I'm coming to this when to use, not to use, and when the thing which leads to the ISR with the patient is the under expansion stent. So most common cause of patient stent failure is the under expansion. So these are the tools that you will use. But the repeatedly I am saying that imaging is very important when you want to see what balloon to be used, what strategy to be used, and how deep you want to penetrate that. So you can use imaging for better use of this. So like this is a cross section where you can see the center one is the lumen. As you move towards outer side, you can see the intima or black cap. The calcium nodules, those are seen in the media. And last one is the adventitia. So we are more concerned about the intimal and medial calcification. Adventitial calcification you cannot modify by these balloon techniques, but you have to think about this intimal and medial calcium, superficial or deep calcium. So mechanism of action of IVL is this. It basically lithotripsy is when there is a emittance of shock wave. This is a schematic diagram. There are different emitters, like the 3 emitters you can see in a 12 mm balloon. When pulse transmits through these points, there is generation and those shock waves in the fluid filled balloon that leads to development of shock wave, which leads to microfractures in the calcium. You can see in this video. So this is a schematic diagram where you can see there is a pulse travels and it produces shock waves in the fluid filled balloon that leads to fracture. You can notice there is a fracture in the calcium. So there are multiple pulses we give. You can see there's a blinking in the left side of the green signal that gives signals to which leads to fracture. So these fracture as these shock waves that propagates towards the intima and media and then leads to fracture and plaque modification. So very importantly, IVL is used for this purpose only, and you can have desired effect with that. So IVL practical technique, the size is 1:1 and it is easily with your workhouse wire we can use this. There is a low pressure sheet, usually 4 to 6 atmosphere pressure is used, and it delivered in the pulses, 10 pulses per cycle, and what shock wave they 80 pulses per catheter available. And we need to confirm the things, like if you delivered pulses to the, then you have to expand, you have to check the expansion, assess the expansion, then you have to look the flow, look the expansion, then you have to deliver the stent. This is the practical technique. Low pressure, you deliver the pulse, you notice the expansion, then you put the stent. So there are various trials for that. In 2021, FDA approved for the use of coronary IVL after this 2 study of disrupt CAD3, and it has very high procedural success. The most important thing is that when you are using IVL, there is a very symmetric, like if a vessel is elliptical and if a vessel is circular. So there is a turbulence less with the circular. So with the IVL, you achieve a very circular profile. So there will be less turbulence and there will be less restenosis. So scientifically, it is very good to use in certain situation coronary IVL. So now a difference between IVL and atherectomy. The two atherectomy what we have, rotational and orbital. So sonic fracture of calcium is a mechanism of IVL, but rotational and is out of scope of discussion both. But the difference you should know, the depth of calcium, superficial and deep calcium can be done with IVL, but this orbital and rotational are mainly deal with the superficial. So it has a very good crossing profile, the IVL, but if there is a balloon uncrossable lesion, you have to straight go forward to rotational atherectomy. So risk of dissection is or perforation is very low because these balloons we inflate at the 4 or 6 atmospheric pressure, and there is a very desired fracture what you have seen. So concentric deep calcium or crossable lesion, the best thing is IVL. If there is an uncrossable lesion, you have to straightforward go to rotational atherectomy. So uncrossable lesion need atherectomy to create a channel. Crossable but undilatable concentric deep calcium favors IVL. So rotatripsy combines both of this toughest lesion. So if you are dealing with this kind of situation, your cath lab, you should have both for a proper management of that vessel. So this is algorithm. Step 1, you have to assess. Step 2, it's crossable or not. And third, if it is undilatable, you can use IVL. And fourth step, optimize after stenting. So a small about peripheral balloons. The first thing what peripheral balloon, similarly what we have studied is POBA, the second drug coated balloon. Similarly the scoring and cutting balloon for the peripheral and peripheral IVL as well. So this is the schematic diagram, how you deal with the different vessels, aorta, iliac, common femoral, SFA, popliteal or below the knee. So like if there is a lesion in the iliac, preferred balloon strategy, PTA plus stent. If there is a calcification, you can use peripheral IVL. If femoropopliteal, you can use drug coated balloon plus minus stent, scoring or IVL. But when you are dealing with the below the knee or in the lower popliteal region, the drug coated balloon you should avoid stent, because these are the flexion zones where you should not use stent, and delivery of stent is also difficult. But when you are dealing with below the knee, always consider POBA and DCB. The role of DCB in coming days, you will see there are packed deep neutral seromillers. There are various IVL under study, and definitely the DCB will play a role in the BTK interventions. So common femoral, popliteal and below the knee segment for compression, torsion and flexion. So they favors balloon based metal sparing strategies over permanent stent. But in SFA, you can consider for stent. So there are evidences for peripheral DCB, 12 months primary patency with paclitaxel. There are various studies in PECT, SFA, Levant and Illuminate. They show that patency endpoints vary by definition, duration across trials. So vessel preparation is very important before doing DCB and a proper lumen gain. So there are various devices you should know. Impact Admiral, Lutonix, Ranger from the Boston, Shockwave, they are used for peripheral IVL, Chocolate PTA, that the same were discussed in coronary. There are groove balloons, there are groove between the balloons. It causes atraumatic dilatation and minimized dissection. And the similarly angiosculpt and Vescu track scoring balloons for fibrocalcific lesions. So, what important thing doing this balloon is important, but you should also know there should be procedural anticoagulation. There should be patient with DAPT or what to give after the procedure. Only DCB is helpful when you allow only shortened DAPT. You're not putting any permanent metal to the patient. And DES and IVL plus stent is a standard DAPT, what you have to give after the procedure. And you should assess the flow after, when you dilate a vessel for pre-dilatation, post-dilatation, in between you have to assess the flow. You have to notice the amount of flow, it's TIMI 2, 3 or 4, or there is a no reflow. So you have to cope up with that situation by using various intracoronary vasodilators by looking for flow in between the inflation and deflation. So pre-treat with intracoronary dilators before sizing to counter spasm. You have to also see for spasm of the vessel. Usually spasm is generalized. So give some dilators, you relieve the spasm, then you select a particular size of balloon or stent. Heparinized flush for over the wire balloons used, and contrast minimization in CKD, that everybody should follow regulations for CKD patients. So what are the complications you can have? Dissection. The second thing is perforation. You can avoid perforations by looking to the RBP of that balloon. And second thing, you can also avoid by overinflating balloon, or like when you are using, like you have to cautiously use in an OPN balloon in a native vessels. You should not every time I use an OPN balloon in a native vessel. It's usually for the post and under expansion after stent placement. If there is a no reflow embolism that can be occur, you can look for balloon rupture. Like any time if you're using a balloon get rupture, you can note that there is a sudden shifting of inflator. The clock of the inflator shift suddenly toward the left side, and there will be blood coming from the balloon. So immediately you have to look to that. If balloon ruptures, you have to immediately take out the balloon from the catheter, and you have to intervene as per, and you have to follow the protocols what's seen. And standard under expansion that you can treat, you know all the mechanisms, IVL or OPN balloon, and drug coated balloon drug delivery failure. If you have DCB readiness point tick to that DCB readiness, your drug will definitely will have a good delivery. IVUS and VOCT are very important when you are doing the complex cases or left main bifurcation, or you're looking to something pathology that you're not understanding with your POBA. So you should do imaging in those cases. So this is the summary. If routine pre-dilatation, semi-compliant balloon; stent post-dilatation, non-compliant balloon; OPN if under expansion; moderate fibrotic lesions, you can use scoring or cutting balloon. If there is a severe deep or concentric calcium, you can use IVL. I am discussing about the balloon only. If there is undilated or under-expanded stent, you can use OPN, high pressure balloons. If there is a ISR, you can use ISR scoring or cutting balloon plus DCB. If there is a small vessel, you can use drug coated balloon. And there is a in peripheral calcified SFA or femoropopulateal lesions, you can use IVL scoring or drug cutting balloon. So these are some cases like 60-year-old diabetic exertional angina angiography shows tight calcified middle end stenosis. When you are using NC balloon to RBP, leaves a persistent waste, so the stent is not expanding. So what is the next step? You can use imaging to confirm the deep calcium and measure the arc and thickness. And if lesion is crossable but undilatable, you can use IVL substrate. And if the lesion is not crossable, you have to use rotablation. So in recurrent ISR cases, you should do imaging to confirm what is neointimal hyperplasia. It is neointimal hyperplasia or underexpanded stent. So you have to differentiate by imaging. You should avoid any third metal layer if possible. And if bleeding risk favors short DAPT, you should give DCB. So imaging and plaque modification is important. So these are the various guidelines which says lesion preparation of calcified lesion before stenting, and use IVUS OCT for optimized PCI. The European shows DCB class 1 for ISR, and there should be imaging guidance for complex PCI. European 2024 shows that reaffirms calcium modification IV intravascular imaging in complex calcified PCI. And ESI 24 also for peripheral endovascular first for many lesions, and DCB for femoropopulateal. And expert consensus shows that stepwise imaging guiding algorithm like balloon, you do pre-dilatation, you do IVL or atherectomy, then you do the OPN if under expansion. This is the streamline what you do. So in future you will having sirolimus drug coated balloons, next generation IVL. Those you can use for BTK expansion, intravascular integration, or there will be more pulses. Now the new pulse, the new machines C2 plus C plus shockwave, they have 120 pulses for peripheral, but in next generation you will see routinely this 120 pulses. There will be bioadapter and scaffolds, metal sparing strategies that will pair with balloon based vessel preparation. There will be image guided automation. The imaging will also give you the amount, the lesion, the length, the arc of the calcium. There will be nano carriers and non-paclitaxel drug delivery for durable patency, and you may have combination therapies with IVL, DCB, pairing for the most complex calcified disease. So these are the 6 points. Read the compliance chart. You should know lesion preparation is everything. The concept is now changed to plaque modification. You have to modify the plaque. The third is escalate by calcium burden. If it is not responding, escalate your device like cutting, scoring, IVL, or OPN for undilatable lesions. And fourth, leave nothing behind when you can. For DCB for ISR, small vessels, high bleeding risk, and coronary and peripheral, where you can put DCB, decreasing the metal load. Imaging is important to decide and confirm, and know the evidence. You should always know what study says and what you have to do. So these are the references what I have taken for this slides. And this valvuloplasty and specialty balloon are out of scope of this discussion. You should also know that balloon valvulotomy, there are various other balloons are used for PTMC, for BAV, and how to size them. Okay, thank you.